You're listening to Addiction Medicine Beyond the Abstract, the official podcast of the Journal of Addiction Medicine. If this is your first time listening, thanks for coming. Addiction Medicine Beyond the Abstract is produced for your enjoyment and is focused on the latest journal-published research and science in the field of addiction medicine. Remember to add us to your favorites in iTunes, and you can also follow us on Twitter at ASAM.org and Facebook. Now, let's go beyond the abstract. Welcome back to another episode of Beyond the Abstract. Thank you so much for tuning in and joining us once again. We've got a great episode for you today. I recently got to sit down with Dr. Bradley Stein to chat about his new study titled Medicaid Unwinding, Association with New and Ending Buprenorphine Treatment Episodes, which was featured in the September-October issue of the Journal of Addiction Medicine. Dr. Stein shares insight into how Medicaid unwinding is tied to an uptick in Medicaid enrollees stopping buprenorphine treatment, as well as decreases in enrollees initiating treatment. He also discusses what other forms of OUD treatment may be affected by Medicaid unwinding and talks about future research questions that came about from his study. Dr. Bradley Stein is a practicing physician and senior physician policy researcher at RAND. His research career has focused on improving access to, quality of, and outcomes from care of individuals with mental health and substance use disorders being treated in community settings. For 2 decades, Dr. Stein has studied the opioid crisis, serving as principal investigator for numerous federally and privately funded studies. He has published multiple peer-reviewed articles related to studies of opioid use disorder treatment, harm reduction, and the effects of state and federal policies, and has provided congressional testimony related to his research on multiple occasions. His work has also been covered by a range of media outlets, including The Economist, Washington Post, and the New York Times. All right, now let's get into today's discussion with Dr. Bradley Stein. First of all, thank you so much. I want to thank you again for taking the time to come on and talk with me today and be on the show. Really appreciate your time. And I want to start, as we do, at the beginning, and I want to ask you about why addiction medicine. Of all the things that you could have pursued, of all the fields that you could have been interested in, what was it about addiction medicine that got you interested, and what has your experience been like up to this point?
Sure. Well, it's my pleasure to be here, and I'm really thankful and grateful for the opportunity. You know, why addiction medicine? I'm a practicing psychiatrist. And although I spend most of my time doing research, I still practice. And quite honestly, like, you can't be practicing psychiatry without both treating mental health and substance use, right? They're co-travelers, they go together. And so a lot of the research I do is informed by clinical practice. And so during my career, it's really been devoted to trying to understand how do we better achieve greater access and improve quality and better outcomes for individuals with mental health disorders and with substance use disorders. And really, if you want to improve access and quality and outcomes, you got to take them on at the same time. And so that is sort of what has drawn me to it. And as I've gone through my career, certainly there are times I spend more time in areas related to substance use, more times in areas related to mental health. But in my mind, they go together as a services and policy researcher.
So kind of getting a bit into I want to dive into your study here. And your study found actually that Medicaid unwinding was associated with an increase in the number of Medicaid enrollees stopping buprenorphine treatment, as well as a decrease in enrollees initiating treatment. Talk to me a little bit about what populations or groups of individuals do you think may be most vulnerable to Medicaid unwinding and these treatment changes?
Well, I think the primary group is obviously individuals enrolled in Medicaid. Although I think actually, as we think about how this may affect the broader system, I do think the impact can be beyond that. But within individuals who use Medicaid, I really think the individuals who are going to be most vulnerable are those who we know are vulnerable and struggle with all kinds of other challenges. Those who may have unstable Medicaid coverage because of various factors that may interrupt that coverage. So individuals who may get involved in the criminal legal system and may lose Medicaid for a period of time. And while there have been policy changes to prevent that from happening as frequently as it used to, I still think those individuals, but even individuals who have a hard time filling out the paperwork, right? Just those types of challenges. I think when we think about that, in particular, individuals whose sort of environment in terms of where they're living and their social supports and families or other supports are vulnerable. Individuals who may be unstably housed, or who may be sort of moving around a lot. Other places that just, other things that make those individuals more generally vulnerable and lead much more chaotic lives. those who live in communities where care is more fragmented, or where there are just less resources, right? Because a lot of the ways that we try to support those individuals are through a range of social programs, and certainly different communities have more robust programs than others. Some of that is due to the culture of the community. Some of that is due to just the resources available in certain communities. As you move out into many of the more rural communities where they just don't have the infrastructure, I think a lot of those individuals could be particularly vulnerable. And then the other population I certainly think about, well, I've talked a lot about social stuff, is individuals who are sort of more medically complex, right? Because one of the things we know is that continuity of care is really important. And for individuals who are more medically complex, if you disrupt one thing, it can start to throw other things off, and then you can just sort of get this snowball effect happening. And so for those individuals, while we tend to think of this just in terms of the treatment of their addiction, I think this idea that we're going to be disrupting care, or individuals who need care may not be able to access it as quickly or at all as they might otherwise, would seem to put those individuals at risk not only for their opioid use disorder, but more generally for other types of comorbid conditions that they may be struggling with.
Mm. Well, I want to ask too, are the trends that you're seeing in discontinuing or not initiating treatment, is it specific to buprenorphine treatment? Or do you think that there are also potential effects of like Medicaid unwinding on other forms of OUD treatment, like methadone treatment?
Yeah, it's a really good question. So in our study, we looked specifically at buprenorphine, but in terms of what we looked at, it's really hard to imagine that you wouldn't see these same type of effects in accessing other types of treatment also. I don't think there's anything particularly unique or special about buprenorphine here that would make buprenorphine stand out in a way for methadone treatment or non-pharmacologic treatments supported by Medicaid. I think all of those types of care might similarly be affected by this and probably affecting the same types of populations.
I'm wondering too, looking ahead, in this study, what kind of future research questions sort of emerged and came out of this study? And how do you think that we can kind of address those questions with future research studies and things like that?
Well, so one of the things that we're particularly interested in now, and actually are in the midst of looking into, is that a number of communities and states took different approaches to trying to mitigate the impact of Medicaid unwinding. And we can think of it as sort of a national experiment. Different places tried different things and may have tried them for different populations. And so one of the things that we're really interested in is really sort of looking at some of those things. Different states took different approaches to trying to either prevent people from disenrolling or make it easier for them to enroll, or at least make them more aware that they were at risk of being disenrolled. And for this population, we really don't have any sense of how those things may or may not have affected what was going on. And so I think that's sort of at a high level, sort of one of the things that I think immediately we started to think about in seeing these results is, okay, we're seeing lots of people losing coverage. Are there things that may have mitigated some of this impact, or are there things that worsened it, right? So I think that's one question that we have. Another one is something that I think we just touched on, is while we looked at sort of the overall population, are there different populations that we can see the numbers that it really did become much worse for us? Or were there populations that really weren't as affected by others here? And I think where that becomes really important is we're thinking and trying to inform policymakers about different options that they may be able to use to sort of mitigate these impacts and make sure that individuals who are benefiting from this life-saving treatment continue to receive it. That helps to sort of shine the light at like, okay, here are the populations that seem to be most impacted. Or here's something you may have done that seemed to have mitigated it. Maybe your state can learn from another state that went down this road. Or here's something that seemed to make it worse. You should be aware of that if that's something of one of the policy options that you're continuing to consider. So I think at one level, those are really important questions. I think when we move beyond that, though, we're talking about people's lives here. And so a lot of the work we're doing is sort of at that 20,000 foot level, sort of saying, here's the sort of societal public health impact that we're seeing from as policymakers implement these policies. But each of those numbers is an individual with a life and a story and a different condition. And so I think it's really important that subsequent research really begins to try to understand, okay, what was the impact in terms of clinical impact, in terms of social impact? Did this lead more people to have problems that led to unstable housing, that led to them going back and being involved in a criminal legal system, that led to higher rates of mortality? Any number of questions that really reflect the sort of impact on the individuals that we're talking about as a collective here. And I think those are critically important questions.
That's really interesting. I want to shift gears a little bit as we come to the end of our show. And I always like to pick everybody's brain for a little bit of advice and wisdom. So I want to ask you, Dr. Stein, what advice would you offer to either your younger self or the next generation of addiction medicine clinicians or researchers, those just getting involved in the field or just getting interested in it? What do you wish you knew when you started?
So one of the things that I think I've learned in working in the opioid crisis for as long as I have is that it's changed, it's evolved, right? If the crisis that we were looking at in 2005 and 2010 is really, really different than what was going on in 2015. It is really, really different than what was going on in 2020 and today. And I think we would be naive to think that, okay, this is where it's going to stop. And I think 5 years, 10 years from now, the challenges that we face, both with the opioid crisis, but substance use disorders more generally, is going to be really very different. And so I think oftentimes, as a clinician, I focus on what's in front of me. But the world is changing around us. 15 years ago, we weren't having a conversation about fentanyl. And the idea of xylazine or test strips was not even something we talked about. And so I think keeping this eye on to how things will continue to change and evolve, it is something that I wish my younger self would have known, and is something that I think is important. I try to keep my eye on it now in sort of where we're going in the future. And so, for example, a lot of the areas in terms of illicit substances, we really seem to be in this shift going from sort of agricultural products to synthetics. And that has tremendous implications for how we think about the harms, for how we need to think about treatment, for how we think about harm reduction, or in other ways trying to minimize the harms and help the people who are involved. And it also has implications on sort of the supply side, right? It's a tremendous challenge on the supply side too. So I think that's one of the things I would do. I would certainly pay attention to. The other thing that I think that we talk about but may not pay enough attention to is how technology is tremendously changing sort of the world around us. We did a study, and it's not related to addiction, but came out a week or so ago, just looking at young people's use of sort of AI, LLMs, for emotional support, not even treatment, but emotional support. And the number of teens and young adults who use those types of things monthly and find them very helpful, 90% of people who use them find them helpful, and they're using them monthly. And so there's this tremendous change, not only in how we practice clinically. I mean, oftentimes when we talk about technology, we think about telehealth, but it really extends beyond that in ways that I think I would encourage people to be thoughtful about and attentive to. And not just it's going to make an immediate change in what we do, but it may make fundamental changes in ways that we think about what we're doing. And I think one of the challenges that I'm particularly curious about is the workforce in addiction medicine is insufficient, and it's not paid enough. And I would love to see a future where that changed, and where the amount of resources that really should be allocated to this area flowed in. I can't look at the world around us and see that happening in the next decade. And so I do think this idea of, okay, the insufficient workforce and insufficient pay, despite our efforts to change that, is likely here for a while. How do we think about what we need to do as a system and society? And again, I would love to change that. But what other things can we do, assuming that we can't get the fundamental changes in that area that we need to make sure that the people we serve are getting as much help as we as a field can provide for them? And so these are challenges, but at the same time, I think they're incredibly exciting opportunities for researchers and for people who are going into the field to think about what the future brings, because these challenges are there and going to need to be solved, because the issue of addiction has not gone away.
Very wise words, Dr. Bradley Stein. Thank you so much for stopping by today.
Zach, my pleasure. Thank you so much for having me. Really enjoyed it.
This ends today's podcast. Thank you for listening to Addiction Medicine Beyond the Abstract. All of today's show links can be found in the show notes. Remember, you can preview additional abstracts at journalofaddictionmedicine.com. This program was produced by the American Society of Addiction Medicine.